Hi, everyone. Good morning. Welcome to our Changemaker series. I'm going to give a moment for everyone to get on the Zoom here and we'll get started. Hi, Cindy. It's nice to see you. Welcome home. Hi, Chaya. Hey, Les. All right. While we're having everyone jump on here, if you would like to tell us where you're from, just go ahead and use the chat function. Make sure you are telling all panelists and attendees and just put your name in and what hospital you are from. We would love to see where people are joining us from. Hi, Sarah. Glad you were able to make this one. Hi, Troy. Hi, Jill. Nice to see you. I was just talking about your program the other day, just bragging about how well you all have done in Santa Clara. Oh, great. Welcome, John Muir. We're so excited to have you. You guys are right down the road from me in Oakland. Yeah. Oh, great. Somebody from MLK community. You've been getting so much press down there for everything you all have going on. Oh, wow. From Louisiana. Welcome. We're a multi-time zone training today. I love it. Oh, thank you. Melissa, well, if there's anything we can do to help you directly in Louisiana, reach out if you haven't already done so. We would love to give you some direct support. Hi, Kelly. Welcome. Congratulations on your new role at Sutter Roseville. Hi, Jane. Good to have you. All right. I hope everyone's having a great day. So I think we can go ahead and, oh, wow, we've got Canada. Wow, we're not only multi-time zone, but multi-country. I love it. Oh, awesome. Yeah, Melissa, I'll send you a private message about that. So I hope everyone's having a really great week so far. We are really, really excited for this training today. This is a topic that's been very front of mind for everybody at California Bridge, and I think everybody, to be honest, since, last summer. So let's go ahead and get started. We're going to begin, before we dive into talking about equity and MAT treatment, we're going to begin by talking about the changes to the X waiver requirements that recently went into effect. We know that you probably are all receiving a lot of questions at your site. Oh, hi, Lee. I want to talk to you about something, Lee at Corona. I'm going to send you a private message. I'm going to have Amy Mulan, California Bridge Director, get us started by telling us about the changes to the X waiver requirements and everything that we are doing to help you increase the number of providers at your hospitals. So Amy, take it away.
Okay, so go ahead to the next slide. I am so excited about this even further. Let's just blow past this one and get to the good information. Okay, so for all of you who don't know this, the X waiver training piece is functionally gone. We have been waiting for this for so long and it is finally here. I'm gonna break this down because it's not completely gone, but the training piece is gone. So what has happened is the administration has eliminated that 8-hour training requirement for you to get your X waiver. You still have to register with SAMHSA to get your X waiver, the same way that you have to register with the DEA to get a DEA license, but it's really at this point down to paperwork. So what you're gonna have to do is go to the SAMHSA website, sign up for your X waiver. We have a blog post if you want the nitty gritties of how to hack the SAMHSA system to get your X waiver without the training. But this is really amazing, fantastic news. So at this point, there is no reason for anyone out there not to do this, because as we all know, this is how we're going to save lives. And all of that training requirement has been eliminated and it's just down to paperwork. And so we all know that paperwork, we can push through it. And so everyone you talk to, sign up for the SAMHSA website, get your X waiver. They're on sale for free now, no training, just sign up. We put a post to our detailed blog post instructions in the chat, but also happy to walk anyone through how to hack that SAMHSA system. Go on to the next slide. So just to say that 8 hours, way too long. We know it. Here at California Bridge, we think we can get this done in 8 minutes. So we're going to put together 8 hours in 8 minutes, which is everything you need to know to start buprenorphine and save a life. So this is coming soon, and just a quick plug, celebrate everyone, because this huge barrier that we've been working around for so long has been removed. And so I think this is going to be a massive game changer in how we're able to provide life-saving treatment. So with that, I'm going to turn it over to our amazing speakers. Thank you all.
Yeah, thanks.
Sign up, ask questions.
Yeah, sign up, ask questions. This is really important and really exciting. And for many of you who are on the training today, who we've known for a while, you probably are getting questions about this. And it's a change in how you're talking to your own champions about how to get people prescribing buprenorphine in your hospital. So I want to pause and take any questions. Has anyone faced any barriers to this? Have you tried to sign up and face some sort of barrier you'd like to share? Any questions about this change?
It is goofy, so I do recommend reading our blog post and kind of walking through it, because you do have to hack the system. You will get an error message, but we've been in constant communication with SAMHSA, and that's all normal.
So Amy, the question from Melissa in Louisiana is this X-Waiver discussion applicable nationwide?
Absolutely. So this is a national federal change. You can, and anyone in this country can, who has a DEA and a valid provider license, can apply to get an X-Waiver without completing the full training. This is also true for PAs and NPs who used to have to do 24 hours of training. That is gone. So all of this, anyone can apply to get this X-Waiver without that training requirement.
Other questions? I see a question in the Q&A. Can medical students still get the X-Waiver without the training?
So in order to have this X-Waiver, you have to have a valid DEA license. So currently a medical student, and even a lot of our residents who don't have an individual DEA, cannot get the X-Waiver because that is still one of the restrictions.
Other questions?
Great questions. And the resident postgraduate training license is currently a super hot topic at SAMHSA.
I see one more question coming in. This is great, but we still want to, wow, this is, did we plant this question, Jennifer?
Yes.
Yeah, Jennifer, I'll Venmo your $20 after this training. This is great, but we still want our prescribers to be trained to know how to prescribe correctly. What trainings would be recommended?
So I think, and this is a big challenge, and you can let me know if I can meet it. I think I can get it done in eight minutes. We're going to host an 8 hours and 8 minutes training for all of your providers. But also anyone who is interested in more detailed information, that is pretty much what the CA Bridge website is we have tons of information, FAQs, treatment protocols, order sets, anything and everything that you might be interested should be up on our website. And if you find something that you think your providers need that we don't have, let us know, because we've really tried to have a comprehensive resource page. But I'd love to hear it if you find gaps. We want to know.
Yeah. So Steve Holtzford has caught on to our sense of humor over here at Bridge. He says 8 minutes sounds a little short. Isn't even working on anything more like an hour. We're just being cheeky, Steve. May 21st actually is scheduled for an hour. It's going to be a full hour on best practices and prescribing, including ample time for Q&A, going over partial agonists, half affinity, long life, half type of stuff. That's exactly what that's Steve's words. That's exactly what they're going to be going over. Can I please ask the communications team to share out the official link for the registration for this May 21st training? A couple of people are asking for it. Jermaine will have that sent to the group in just a moment. I have time for one more question. Let's see what's in the Q&A here. We've had some resistance at my hospital in Illinois. Jennifer, I would love if you want to share more about that. Tell us what kind of resistance you've had. We are happy to, if you reach out to us, we're happy to get you on the phone with Amy here or somebody else who can coach you into how to respond to that resistance. You name the resistance, we've confronted it as a program, and we're happy to, this goes for anybody on the training today, anybody who's facing resistance, just wants to think about how to respond to certain barriers. that is what we do as a program. It's a big part of what we do. And we understand that culture is often the most important part in getting people prescribing. So yeah, awesome. Thanks everyone. More questions, feel free to put them in the Q&A and we'll make sure that we reach out to you to support. And overall, always keep in mind, you can contact us at any time using the contact form on our website or reaching out to me directly. And I can usually get someone on the phone to answer a question for you within a couple hours. So great. Meghan and Raul, take it away.
Thank you. Thank you, everyone. And I just want to first start off with thanking the Bridge program for all of the support in getting this done. There's so many people in the background, and Meghan, thank you so much. But I just wanted to first start off with our maybe our objectives here and continue to go through our presentation and handing it over to Meghan. Did we want to do any introductions, Elizabeth, or we just go right through?
Why don't you introduce yourself and then pass it to Meghan? She can introduce herself and then we'll dive in.
All right. Well, I'm Dr. Raul Ayala. I am a family medicine doctor by trade, and I serve as the ambulatory medical director for Adventist Health in the states of California, Hawaii, Washington, and Oregon. And love being a part of this, which is kind of a special place in my heart for what we do here. And Meghan.
Hi, everyone. Hopefully you can see me. Nice to see all you, and so thrilled to be here with Dr. Ayala and the California Bridge team. My name is Meghan O'Brian. I'm a hospitalist and general internist at UCSF, and my practice site is San Francisco General Hospital. I'm also one of the regional directors here with Dr. Ayala at the California Bridge Project. Nice to be here with you.
Well, thank you. And I'll just quickly, we're in for a ride today, and it's exciting to be able to present this with you. And I'll just kind of quickly go through the objectives and pass it back to Dr. O'Brian here. It was really, the presentation is really centered around the basics of, just thinking about what are the definitions, what is the background, what is equity, and how do we approach these areas in our practice, in our organization. And then finally, just thinking about our techniques and maybe some future state research and other really important and futuristic type projects that are happening out there. But I'd like to just turn it over now to Dr. O'Brian here. Meghan, thank you so much. Take it away.
Great. Thanks so much, Raul. Just a brief overview and roadmap for today. So we'll start with the impact of inequities, looking at unequal outcomes. Then we'll talk about some of the forces that got us here and how to apply an equity lens to taking action and organizational strategies. Because we'll be talking about how to weave equity throughout our work, and because part of an equity frame means prioritizing impact over intention, I want to start with disparities and outcomes that make pursuing equity so vitally important. In this presentation, I will lead with racial disparities because they cut across all characteristics and persist when other characteristics are controlled for. And so all forms of disparities and equity are important to address, of course, and in particular, the intersections of different identity characteristics that face marginalization and oppression. But because race is the amplifier of inequity across all identity characteristics, we lead with race. And so what we're going to take a brief look at the disparities that we must confront. So the impact of the opioid epidemic has been disproportionate. And while the epidemic has often been characterized as a disease more heavily impacting white people, which in itself is due in part to inequities Black people and people of color face in accessing adequate pain control, which can sometimes serve as the entry point into opioid use, there are important inequities that we have to center in our work. So in this chart, we see that while rates of overdose are increasing for all races, that the green line representing overdose among people identified as African American is crossing all of the other lines, reflecting an accelerating overdose rate among Black individuals. And we know that these results are not due to some inherent difference in patterns of use, but rather by lack of access to treatment. COVID introduces a double whammy to this disparity. So this is a retrospective case control study of EHR medical record data for over 300,000 patients that captured what many of us know from our work, which is that patients with substance use disorders, particularly opioid use disorder, were more likely to be hospitalized and to die of COVID-19 than people without substance use disorders. And that burden was driven disproportionately by disparities in COVID burden and outcomes among African-American identified patients with substance use disorder, as seen in this chart, where the blue bars represent African-American patients and white patients are represented by the orange bars. This reflects death rates, but this is similar with hospitalizations as well. We see, unfortunately, similar disparities along racial lines echoed for pregnant patients with substance use disorder. So while Black and white patients have the same rates of urine toxicology positivity, data shows that Black patients who are pregnant are tested more often for urine toxicology screens, which has downstream cascading implications for involvement of child protective services and may also serve as a deterrent to patients seeking prenatal care, which has additional associated ramifications for the birthing patient and the fetus. Additionally, Black and Hispanic identified pregnant patients are less likely to receive pharmacotherapy for OUD. And when they do, they're more likely to receive methadone instead of buprenorphine. Those who receive bup are more likely to be married, employed, and have more education. So again, recognizing the intersections of different identities in terms of access to treatment and equitable care. And then finally, again, we're just dipping our toe into the water of some of the disparities that persist in sort of the realm of substance use and opioid use. But I would be remiss if I didn't mention the disproportionate impact on Black and Hispanic communities from disparate drug laws and enforcement. So despite a much lesser representation in the national population, as evidenced by the bars on the sort of clustered on the left, where we see white patients in blue, or white people in blue, Latino people represented by the yellow bar, and Black people represented by the orange bar, we see that in terms of people who are incarcerated in state and federal prison for drug offenses, that Black and Latino people are disproportionately represented, an outsized share of incarcerations for drug offense. And this has impact on these people directly, but also on their families, their communities, and the impact is enormous. So looking at this data in isolation, one might wonder, oh gosh, is there some difference between the races that accounts for this? And the answer is a resounding, scientifically proven no. There is no genetic difference, no scientifically, biologically based difference between people of different races. These results are a result of systems and policies that were designed to produce inequality. And what we're seeing is a downstream consequence on the health of people, families, and communities. Right? So America was built and founded on a system of slavery meant to systematically prioritize white people at the expense of Black people and people of color. And we're seeing those legacies reverberate through the systems that affect our experience moving through the world and our internal biases and how we deliver care. One way that these systems, sort of historical and contemporary, manifest is in our institutions of which we are a part and in us as individuals. So this diagram comes from the Center for Social Inclusion and captures how structures and policies that maintain inequality and are institutionally driven and individually upheld through both explicit and also implicit actions. So an explicit institutional policy might be different legal penalties assigned to crack versus cocaine drug offenses, whereas an implicit institutional policy might be selecting a candidate who shows the most promise, right? Sort of coded language for selecting someone that is familiar or maybe sort of teasing out sort of race there. It's coded, it's not explicit. Individuals may discriminate overtly, which would be explicit, or their unconscious bias from having sort of been reared and spent time in the system in the United States with its baked in inequities and disparities might impact their clinical care decisions or how they outreach to community. And so one example of how policy and structures drive outcomes and disparity is that of neighborhood segregation. So a cross-sectional study of over 3,000 counties in the United States revealed that highly segregated African-American or Hispanic Latino communities had more methadone facilities per capita, while segregated white communities had more capacity to provide buprenorphine per capita. This is an inequity that is baked into our care delivery system that impacts how patients can access treatment, and this in turn drives disparities. We see similar disparities sort of reflected in the distribution of ex-waivered OB providers. So again, a cross-sectional nationwide study looked at 31,000 physicians, obstetricians, and found that fewer than 2%, under 2% of OBs were able to prescribe buprenorphine. Those who were able to prescribe were more likely to be in suburban areas with lower uninsured rates. And so again, thinking about segregation in communities of color and who has access, they're also likely less likely to have hospital privileges. So thinking about the points of access and treatment for addiction. This again is how the structure of our healthcare delivery system that has inequities and that's impacting access. And what we see sort of on this national trend, and we can go to the next slide here, is that these trends play out locally. So what's about to come on the screen, doing to the next slide, thanks so much, is that this is data from the California Bridge Project that shows rates of bupe prescribing here in California, and that they're inversely related to the whiteness of the neighborhood. So the whiter the neighborhood, the more bupe prescriptions are being prescribed. And this is true even though opioid-related hospitalizations is nearly even. So on the next slide, we can see that this is not driven by a difference in consequence of opioid use disorder, right? Hospitalizations for the consequence of opioid use are nearly even in these areas. And so if we go to the next slide, it's important to realize that neighborhood segregation and associated inequalities to access to care didn't just happen by accident, but rather segregation was driven by US federal policy, and the consequences of this policy are still reverberating today. So way back in the 1930s, the Federal Housing Administration was created, and it refused to insure mortgages to African-American neighborhoods, designating these neighborhoods as hazardous and marking them with a literal red line on maps in a process known as redlining. And this effectively roadblocked investment in Black neighborhoods and communities and homeownership for African-American people, and subsidized investment and generational wealth accumulation and consolidation in the form of home equity in white neighborhoods, all of which served to drive and entrench racial segregation as people followed the money. These forces driving segregation also undoubtedly influence the tax base in areas and the social structures that sprung up in those neighborhoods, which impact healthcare delivery models that are available to local communities. And this is but one example of how policy and structures drive outcomes. Another example that is probably familiar to those who do addiction work is, that impacts the experience of people who use drugs and the care that they receive, is the war on drugs. So in the 1970s, Nixon war on drugs cemented the federal stance towards addiction and drug use as a criminal issue that needed to be punished rather than a medical issue that required treatment. Reagan expanded the war on drugs and Bush Jr. militarized it. And the result has driven incarceration for drug offenses that are disproportionately felt by Black and Latino people who use drugs due to disparities in the laws themselves, policing practices and opportunities for engagement with the police, as well as sentencing. And again, this impacts people, their families, and their communities. This national this national narrative also impacts us. So study after study shows that stigma impacts both patients and people who use substances, who use drugs, their relationship to recovery, their relationship to treatment, and it also impacts and biases providers and the clinical care that we offer. So again, thinking about how the systems, these national narratives impact and have these consequences that flow downstream and impact the patient on a real and tangible level. So what do we do? Well, we need a frame shift towards equity. And we'll talk for a second about what that means. I wonder how many of you, perhaps all of you, have seen this graphic depicting the difference between equality and equity, right? We have three people who want to see a baseball game and they have different heights, and so some of them can't see. Equality is depicted as giving everyone an equal leg up, sort of an equal step stool, whereas equity is giving people the height support that they need to achieve the same outcome, so seeing the baseball game. But there's an inherent flaw in this model, which is that the disparity here is depicted as intrinsic to individuals, right? That people are of different heights. Instead, I want to shift our equity frame to one that better reflects the structures that drive disparities, which we can see here on the next slide. So in this slide, we have people of the same height. same stature, facing an increasingly tall fence and a sort of an increasingly low sort of land that they're standing on, which results in the disparities in the outcome, which is seeing the game. So again, the structures here are driving the barriers. And once again, equality is same as giving everyone the same thing, treating everyone the same. Equity here is fairness, giving people what they need to achieve the same outcome. And to take that a step further, justice is dismantling the structures that create the opportunity gap. And some might argue, giving people a ticket to the game so they can get a front row seat, right? So there's some flaws in this model, but just to reinforce this point, I hope you'll bear with me here. So we want to dismantle these structures. And so what does this mean in terms of taking action, right? We have to identify what maintains inequity so that we can begin to disrupt it. On the next slide here, what maintains inequity is first that it goes unnoticed or unexamined. So imagine you're the umpire at that baseball game and you're looking out and you say, oh, there's a person looking at the game, glad he's getting a view. But unless you creep up to that fence and peer over at who can't see and what are the things that are preventing them from seeing, the inequities here that create the disparities go unnoticed. So we have to pull back the curtain and look intentionally and deliberately to see where these inequities lie. And then we have to focus on changing the structures, the policy, and the people that maintain inequity. And we need a plan for accountability because lack of accountability allows inequities and the disparities they produce to persist. So I invite you now to put into the chat, what are some of the things that you've noticed that maintain inequity where you work? I'd love to hear from you as we move through the next portion of this presentation. We can go to the next slide. I think there's one right before this. No, okay. Well, we'll start here. And so we're thinking about, we want to identify the inequities, right? So we talked about peeling back the curtain and taking a look over the fence. And one way that we can do that is by centering the margins, right? We have to focus on whose voices have been excluded or suppressed even, and how do we elevate those voices and center them and believe them to identify where the inequities are occurring. We want to do this by taking a race-conscious approach, not a race-blind approach. This is not to say a race-exclusive approach, right? But because race is the amplifier of disparities across all other characteristics, it's very important that we focus on race in addition to all the other things that sort of aspects of identity and axes of identity around which people experience marginalization. And then we have to importantly measure and trend the equity metrics. So if we're not naming it, if we're not identifying, if we're not measuring, we can't track it, we can't trend it, we can't see how we're doing. One of the really exciting opportunities that we have here at the California Bridge Project is that we can hone in on structures and that we are working collectively to change structures and systems of care. And one way we can think about this is by following the patient through these structures. So the patient exists in the community, and then they may be hospitalized, in relationship to their drug use or in relationship to something else. Our sons or substance use navigators expertly connect them to care in the outpatient setting so that they can return to the community. Some patients may be justice involved. And so within each of these institutions in these realms, there are additional structures that patients engage with and policies that patients engage with that impact their experience and their outcomes. And so I think there's a few more animations on this slide that we can just advance through. Great. And so this is where we can begin to shine the looking glass. And we want to, again, take a focus our actions and our efforts on structure and policy. And one way to do that is to ask ourselves, who makes it in? What do they experience when they're in care? And then are they retained in treatment and care? And so when we think about who makes it in, who gets the invitations into care? Are people justice involved in ways that exclude them from care because we're not adequately offering MAT in the prison or jails? Who has knowledge to the resources? And that can go as far back as who's getting educated in grade school and elementary school about safe drug use and practices. whose communities have been historically oppressed and exploited by the healthcare system that creates a rational fear response to engaging with the system, and how do we combat that by making it safe? Who has access to telehealth, who's digitally literate and has the devices, and who can access across language barriers? And when they're in sort of the care system, then we have to ask ourselves, how are people being treated, right? Are they being welcomed, or are they being sort of stigmatized and marginalized? Who do they see? Is it people who look like them? And that goes back to our hiring practices and policies. What medications they have access to, what's on formulary, who's making the clinical decisions, and are those biased? And for example, a policy around urine toxicology in pregnant patients would be very helpful to promoting equity-driven application of urine toxicology. Is there a police presence, and what does that do to communities who are historically and currently traumatized by police interactions? What does the very presence of police mean for the safety of that environment? And again, language barriers and institutional priorities all manifest in the experience of the patient. And then when patients leave the care system or immediate care system, thinking about emergency department and inpatient care and transitioning to the outpatient realm, what support do they have to be retained in treatment? Do they have insurance coverage? Are they going to a place like jail or prison? And does that jail or prison have reentry support for patients with use disorders? Are they able to get into primary care? Is it close to where they live? Do they have transportation or language barriers? Do they have access to wraparound services? So again, sort of thinking in a systemic way about the experience, and then looking at the policies and the structures that drive that experience, is one way to approach equity in our work. And because we can't do this alone, we have to focus on developing people. That means developing our attitudes, our behaviors and skills, and our priorities. Attitudes are things like, excavating this war on drugs from our mind and our language, and really framing addiction as something that needs treatment, making our care dignity driven and person centered, developing behaviors and skills for debiasing our work, approaching with humility, relationship building, changing our stigmatized language to be more supportive, really taking anti-racist action. What does that really mean in terms of outcomes? Really elevating our powers to advocate, so we can advocate for change on sort of a national level and sort of policy level that impacts our patients. And then a prioritization. So can we get buy-in from the top down and the bottom up? Do we have an accountability plan for ourselves and our own individual work as well as our institution? Do we engage in a practice of reflexivity that examines our work, our efforts, and our biases? Are we committing to using interpreters for language access? Are we building alliances with communities and having active, intentional allyships? And are we centering the margins? So again, developing our people here. And then above all else, what it means to apply an equity lens to our work, which we can see on the next slide, is that we have to ask, what did we do and how much did we do? We have to prioritize the impact over intent, and then live with the question throughout everything that we do is who is benefiting and who is being burdened by our decisions, by our policy, by our projects, by our efforts. And then we have to ensure accountability by figuring out a plan for communicating results. And there's a really wonderful toolkit that hopefully they'll put that's in the chat I see from the Government Alliance on Race and Equity that you can take back to your project and your organizations. And with that, I'll turn it over to Dr. Raul Ayala to review some areas of organizational focus and strategies.
Thank you, Megan. It's a great overview, great job on that piece there. And I'm so happy to have worked with this with you. As we went through what Megan described on the overview, some of the strategies, I wanted to transition us into areas of focus for organizations like ourselves. We here as a group are working in a cohesive, area, and what do we bring? What do we do? And so there are some national and international organizational strategies to bring equity, but I kind of wanted to just pose that question. What is anyone, or I would say the participants, are we maybe focusing in on, or maybe the question is, and you see a poll in front of you, have you implemented an equity strategy within your organization, your group, your work? Are there any conversations that you're having now? Are there any plans? Is this part of your dialogue as you go through your workday or with your organization, or even in meetings? Do we tend to think about equity? And I think I can answer myself, or also I can't vote, it says here. All right. And so can somebody tell me if we can, there it is. So that's great. The majority of people are working on developing one, but we do have a substantial no, which brings me to the next piece there. And thank you all for doing that poll. And I'm happy to see the 23% in yes. So that means some of us are working on that. And if there's 80 of us, that's probably a quarter. But I wanted to just think about and not go too much in detail because Megan covered a lot of that. But if we take a look at, where are we? Where do I live? Where do I work? What do I see? What do I experience? And really the question is, what can I do? So what do I do in my organization? But if you think about that, and I think about the healthcare providers or the sons and all the other healthcare providers that are involved, and even administrators, what you have in front of you is really what was taken from the Department of Health Services on the workforce. And if you take just that one snapshot from 2011 to 2015, if Megan talked about a disparity and the differences, you can see of our health occupations, who actually occupies them and what are our backgrounds. And if you take a look at that, there's quite a disparity. And somebody in the chat mentioned education, which is really important to start this frame of what do I do, right? And what do I bring? And how do I approach this in a systematic or comprehensive approach? And so the next slide really takes us into that beginning piece. If I can get the next slide. In our environment, what do we encounter? Do we create that welcoming environment for these patients? Does our medical staff and our ancillary staff, do we relate? Do we have the same backgrounds? Do we speak the same language? And then with this particular patient group, what kind of approaches do we have? What kind of beliefs do we come with? And also, how do we empower patients in the manner that they feel that they can accomplish? And a lot of it is, what do we do, right? And what can we maybe drive or lead our organization into discussions? And I think that's really important, where I know we've talked about this in the Bridge project about, just maybe thinking about this without the anxieties and really not looking at it from a frame of they are different, but more of how can I help? And how do I maybe empathize and put myself in their shoes with just the interactions? So that's one thing, right? And the next slide starts to talk about, so this is actually some recommendations from the National Institute of Health. It says, if you are in a part of a group, or your organization or your job, what can you do? What can you be a part of? And a lot of that is, how do you start to really pay attention to what your environment is like? What is that racial climate? Are there motives, or is it just in general around disparities, around social determinants, around stigmas? How do we start to think about or provide and capture data around who our patients are? How do we start to build educational tools, ongoing, continuing education around these areas? And I think Megan touched on something really important around policies. How do we drive policy change? And a lot of it, we might be thinking about, how do we start to even begin a training or a framework? And I can tell you that all of us are in a environment where we can make those changes. We can ask the questions. We are in those meetings, whether they're small or large. We can start to think about these recommendations and maybe just saying, hey, I think somebody, and I'll reference the chat here, they said, do we have interpreters for different languages? Did I do my best to communicate with this patient? And do we have the tools, not just in my facility, but in all the facilities? And I know that those are stepwise approaches, but they're very key points to what can I do? What can I do in my environment? The next slide talks about and I actually like this scorecard. Meghan touched on it a little bit, and she mentioned that there are extensive work that's happened in organizations to look at a comprehensive and systematic approach in the influence in the care setting and healthcare organizations around disparities, around equity and inclusion. And so this is an inclusion scorecard that kind of tells you 4 areas of I would say focus: metrics, culture, which involves training, and then a lot of it is linking and making sure that the interventions or the policies that we are implementing are actually making a change in our environment, our communities. And the other thing is, and I know there's a lot of great work happening within a group in equity here at Bridge, where we had a meeting yesterday and we were talking about the education that needs to happen. The education that needs to happen on a very basic level, all the way to organizational structures, policies, and improvements. But I think we're on a journey here. And I think the take home really is, what can I do? And there are various simple ways of just asking a question. And so these are the frameworks that I think you'll begin to see more of. Next slide. Because the future research and a lot of if you look at some of the ongoing government policy and funding and grant proposals and even laws are coming about from an organizational standpoint to look at not only local, state, and federal organizations, but how do we implement these ideas and concepts into a structure that will enable us to make long-term effects into a system where it involves all of us. And I think that's really important, because that's how we'll really start to make change. And I think just being here today and listening and asking ourselves, what can I do, is really going to make a difference in how we continue this journey. And I know that this won't be the only presentation. I know there will be a series of events for this presentation, but it's a very important topic that I think many of us can relate to. And we see this already in our own environments. With the next slide, one important thing here is, what is one action that you will take to drive racial equity at your home institution? One important thing, and many of you have already chatted. You already put your place there, but from us in this project with Bridge, in this presentation, what will you do? And just think about that for a second and say, maybe we can use the translator more. Maybe we can provide some education to our staff. I don't know, but I posed that question today, and really it's our ask, is what is that one thing that you're gonna maybe do different or ask about in your organization, in your environment? Let us know in the chat. And I think with that in mind, I'm just thankful to Dr. O'Brian and everyone else at the Bridge program with the presentation. But I think here, Elizabeth, we're on to the last slide, and I'll leave with that question for both Megan and I.
Yeah, so I would love to give folks a moment to think about what one action they're going to take to drive racial equity at your home institution. Let's get a couple of answers. So Melissa says using and hiring people with similar lived experience to serve participants and to shape our program structure. That's so important. Megan, I know that you have been a fearless advocate for hiring people with lived experience and paying them equitably to be in these peer navigator roles. Do you want to speak to that at all?
Yeah, I think when we take a look at our workforce and sort of the demographics of our workforce, it's really easy to hire people who are familiar, have familiar experience. And so one way to increase access through the pipeline is to take a step back and look at actual policies that we use when we're hiring people. And here I'm seeing a sort of a really strong example from Melissa is prioritizing lived experience and prioritizing the expertise that lived experience offers. So whereas, a traditional sort of hiring practice in HR may say you have to have X and XYZ sort of educational criteria. That's a hurdle that excludes and prevents people with the deep expertise that serves our patients from potentially being in a role. And so thinking about how we value that expertise through every level of policy, the job description, where we're seeking and recruiting people from, and then also how are we paying people and how are we doing it transparently and equitably to value their expertise. So that can be one mechanism.
Yeah, Troy says constant reminders using all communication modalities, overwhelm people with the info so it's always on their mind. Troy, that's one I struggle with here at the Bridge program. We are always trying to walk that fine line between overwhelming people with all the information that we have and not annoying you. So it's good to know that you agree with that tactic. Deborah says, we're currently developing staff education modules on OUD and sensitivity. Definitely reach out to us if you want some help with that. If you want us to go over it, have our partners, the National Harm Reduction Coalition, review anything, looking for stigma that might be hidden or subtle. And Lee at Corona Regional says, start that conversation. Yeah. And knowing is good until it finally clicks. We agree. Yeah. Raul, what do you have to say about starting the conversation? I know that that's something that you are a pro at getting people to engage.
Well, I actually, as the work through this, it's actually made me more aware, sitting in different meetings and, looking at structures. So Megan, I love the fact that you touched on the policies, having an agenda item to have something, I sit in various committees and just having that really important thing that Megan mentioned about the equity lens, where somebody asks the question, did we forget something? Did we, somebody just at the end of a meeting or through the meeting, just, the group of people get talking about, a procedure or a process. Did we include, or did we talk? I mean, even just pausing and asking the question really gets people to say, oh, well, tell me more. Tell me more about how you would change that. And it builds a dialogue. And I think it brings people to comfort to talk about certain things that you were not normally, it's just normally not part of a conversation during a formal meeting or an informal meeting, but it allows you that space to talk. And I think it brings people that easiness of it being part of what you do.
Yeah, the normalizing force, right? You model it, becomes normal, it shifts culture. And, we have a lot of work to do nationally, but that's one place you can start. And so I love that idea of normalizing.
What else? What other actions are people thinking about as they listen to this dialogue? What barriers do you face when you try to bring up equity within your organizations? We'll pause and let people share in the chat.
I might offer while we're sort of waiting for folks to come into the chat, is that sometimes people get caught up in their own stuff about about whether or not, this is a personal problem, that maybe outcomes are unequal. And I would just sort of encourage us to sort of put our own stuff aside and really, really think about how we are prioritizing outcomes over our own sort of goodness and our own intent. I've seen where, providers are reflected data about sort of patient outcomes and patient experiences, and they think, well, I'm treating everyone equally, so this can't be a me problem. This is like another person's problem. And it may just simply be that because people have inequitable experiences, they need different attention, right? And so it doesn't have to be that you are unequal or biased in a particular way, but that maybe we're not compensating for historical abuses enough to make people feel cherished and welcomed and valued. And so really just thinking about how can we do that to make up the difference, to repair some of these like deep wounds that our society has.
Yeah, so I like some of the comments that are coming in, talking about impact over intent. I think that a lot of us who start to think about these issues proceed to struggle with this question of impact over intent. I really relate to what Melissa says. I often have a very good, passionate intent, and it takes me a while to realize my intent doesn't affect impact the way I wanted it to. It's the person with lived experience who brings me back to reality. And then I think that that's goes really well with the comment that came after it, which is Cindy says we should be using sons to engage the clients, really allowing the sons to meet the patient where they're at in the way that providers either might not be ready for or might not necessarily have the bandwidth to at every moment. So Kara shares that one barrier she faces is people in positions of power being defensive when engaging with this type of work. I imagine that both Raul and Meghan, you could probably speak to that for another hour and we'd still be here. But what do you have to say about talking to people in positions of power about equity?
I can tell you from my experience that, a lot of it is individual. I know that, so Ian says, on the chat also a comment about adjusting your approach. I think that's really important. I think you have to adjust to every individual and every department that you may face, whether that's pharmacy director to a congressman to whatever you want. You always have to adjust to and hear what is their goal, what are they trying to accomplish, and how does this fit into that. So I love the modifying your approach, because that's ultimately the win-win situation. It's not a tug. It's actually you both can win. It's just the dialogue. I think approaching it from a dialogue perspective.
Meghan, what do you think?
I think that's totally right. So aligning your missions and values and starting from a place of sort of legitimizing that everyone wants good outcomes for the people they care for. One other thing that can be helpful in bringing people on board and sort of cutting through their emotional resistance or fragility is to give them a role and a tool, right? So you can say, I would love for you to be the equity, on the equity champion here, and like help us figure out how we're measuring our impact along lines of race, right? So a role and a tool can be a good starting point to bypass some of the emotional resistance. And there's many roles and many tools, right? But if you focus just on one, then people start to feel like they're part of the change and not sort of being blamed for something that they might have emotional barriers to.
What else? What else is coming to mind? Feel free to tell us in the chat. We'll let a couple more comments come in. Think about what action you can take to drive racial equity at your home institution, or tell us what barriers you face when you engage with these. While we're waiting for a couple more comments, I want to tell you about what we have going on. So this Changemaker series, thank you so much for those of you who've joined us for several of these. Please remember the recordings are always available if you'd like to share this content with your team or your colleagues. Some hospitals have been very successful with using these recordings as staff education or like in place of a grand rounds, particularly when people are still participating in virtual events. So our next two sessions are going to pivot a bit and go into some advanced clinical training. So we get a lot of questions about once folks get comfortable with basic MAT starts, what to do next, and what some of the more advanced and less utilized treatment modalities that we know about are. So The next session is going to be on June 18th with Andrew Herring, who's one of the founding directors of California Bridge, and he will be lecturing and then answering questions about advanced buprenorphine. So that's injectables and other forms of buprenorphine that are less commonly used. So please do share that with any clinicians in your network who might be interested in learning about this advanced topic. And then if I can see the next slide, the next training we have is for our nurses. So we have a very robust nursing team here at California Bridge. We have 2 RNs on our full-time program staff, and then we have RN who is an expert in MAT implementation, as well as 2 NPs who have been very successful within their own organizations, who are continuing to develop a robust nursing program for us. So any nurse champions at your hospital, or any nurse who you think might become a champion with a little bit of extra education and emphasis, please encourage them to participate in this training on May 25th. And next slide, please. Q&A, and here we go. Here's everything we have going on. I know we shared a lot of resources with you today: Waiver training, changemaker training, nursing training. Everything is on our website, which is cabridge.org. So anything you need, if you're not sure where to find something, just reach out to us, and please follow us on social. We have really fun Instagram stories if you're into that kind of thing. So time for about 1 or 2 more questions here. Ian shares that he spent a long time working with peers implementing SBIRT programs across Maryland, and it's vital that they're trained so they can really meet folks where they're at and not where peers want them to be. I think that's interesting. That's an interesting point, meeting folks where they're at and not where the navigators or the providers want them to be. Do either of you want to speak to that concept?
I'm sure I can speak to that. Yeah, so I think this is a really great example of a way that we can support developing people with the skills that center the patient. By centering the patient, we cut through our own biases and really support them sort of achieving their goals to accompany them well. And so one approach to driving equity that you might take away is learning from Ian's experience and really supporting MI training for the folks who treat patients with use disorders. That's a wonderful example of a practical application. Thank you for offering that.
Yeah, Raul, anything you want to add?
No, nothing to add. I just maybe a comment on. I think we've had Elizabeth and Meghan and staff. We've had a lot of comments around education. It's resonating from a meeting we had yesterday around the need for, and it almost seems like at every level, right? Sons and I don't think we're experts at all in, and knowing process and et cetera, and implementation. I think that's definitely an area that I'm so happy that we are going to start that journey. Because we're hearing it from the participants that we might need more of that.
Yeah. So another plug, thanks Raul, another plug I'll put in is to use California Bridge as a resource to think about equity in your program. People like Meghan and Raul are not just able to brilliantly guide you as to how to understand buprenorphine dosing, but they also are able to have conversations with you about how to talk about equity in your implementation, how to think about it, and how to present it to those people in power who were mentioned in the chat. So, always just know that we're here to support you in whatever your goals are with your program. Some of the more, the harder skills like actual MAT implementation and dosing and prescribing, and also some of the more culture-driven questions like how to advocate for the value of hiring a son with lived experience, or how to talk about equity in this type of program. So we are here for you. And with that, we'll keep this chat open for another couple of minutes in case anyone has any more questions for us. They can even be just general bridge questions that you might be holding on to. And we really look forward to seeing you in June for the advanced buprenorphine session, and hopefully before then. So I hope everyone has a really great day and a good lunch. Yeah, thanks, Melissa. I'm so glad you're engaging with us from Louisiana. I see somebody with their hand up. Les, go. Do you want, Carolyn, can you unmute Les and Lisa? Lisa as well? Jill, yeah. So Les, you should be able to talk if you take yourself off mute. Lisa, it looks like we're getting you off mute.
Very good presentation, guys. I really like it, but then the question I had is a little bit different, and I don't know if Amy Mullen is still there.
Amy's here, yep.
Yeah, I'm here.
So Amy, I have a different take on that 30 patients, and I don't know if you had a chance to see the article in New England Journal yesterday. I put it on Slack, and actually, and it talks about the Waiver. And my feeling is, for the hospitalist and the emergency physician, that number really doesn't affect us. And it's a carryover from, the data 2000, because we don't actively carry any patients. So I think it only applies to the 30 that you are working on, because remember the data 2000 wasn't just prescribing buprenorphine. You had to counsel them. You had to do behavior modification. We don't do any of that in the hospital and in the ED. So as far as I'm concerned, unless in a shift you are writing more than 30 bup, prescriptions, that's the only time you can get in trouble. So I don't think that 30 applies to the ED or the hospitalist.
Yeah, functionally, I agree with you. We've talked a lot about this in terms of, the hospitals. And I think this question was posed from ASEP to SAMHSA. And you're absolutely right, because from the emergency department, we're not like carrying a patient load in the traditional sense. And I think functionally, unless you're writing, like, as you said, 30 prescriptions every week, you're not going to hit it. So I've kind of counted as like, as long as I don't have more than 30 prescriptions out there, you really can't count those towards my total. So functionally, I don't think that this is really relevant from an emergency department. So I wholeheartedly agree with you, but I'm going to read the New England Journal article. Thank you for bringing that.
Right, and the only reason I'm bringing it up because, Dr. Poorman, I think I've heard of her before. She actually wrote a very good article. The only thing is she felt sorry for us in the ED because of the limitation of the number 30. And I felt like, oh, I need to write a response to this.
Yeah, I don't think they fully understand the way that we practice. Yeah. Totally.
So, yeah, if I can ask the comms team to end the webinar, Raul, I actually have a super quick question for you before you log off. And have a great rest of your day, everyone. Les, I think we're going to lose you when we end the webinar, but we're here if you need to reach out. Yeah.
Thank you so much.
Yeah.
Great presentation.
It was, wasn't it? They're great.
Yeah.
I'm really happy about this one.